The purpose of the following presentation is to examine if drawing blood off an initial intravenous or IV is appropriate and will give accurate blood samples. There are both arguments for and against this controversial subject in the nursing field. I chose this topic due to the policy where I work at in the Bronson Battle Creek Emergency Department. The policy states, do not obtain blood for specimens during IV start or from an established IV. In the policy below this, it has the following exceptions. The exceptions are drawing blood for cultures, pediatrics, NICU, and if necessary during life-threatening emergencies, drawing from an IV start is appropriate. The reason I chose this topic is because I disagree with not being able to draw from an IV start for numerous reasons. I have talked to many other nurses about this controversial topic, and they all agree with me and how many other facilities allow nurses to draw off of IV starts. In fact, small hospitals may not have phlebotomists in the emergency departments, and the nurse does everything. And I had this specific situation in one of my clinicals. After this presentation, the viewer will be able to describe hemolysis, what labs are affected by it, procedures to obtain a sample, and how to prevent hemolysis to obtain more accurate results. The background of why IV starts or any other blood draw procedure obtains inaccurate samples is due to hemolysis. Hemolysis is the main cause of lab specimens being rejected. Hemolysis can be described as the rupture of red blood cells with the release of hemoglobin and the intracellular components into the plasma. It is argued that IV draws and other factors can cause this. Below is a table of a few labs hemolysis can affect, but overall it affects every lab value in some way. One of the more important lab values it affects is the clotting factors like PTT and iron R. With these labs affected, the plan of care for a patient can be altered, and a physician may choose to give medications that are not necessary and treatments as well. The following slides are in order of reliability, with this first study being the strongest evidence I found. The study was done in 2014 with over 54,000 samples. Samples were taken to measure hemolyzed blood, and the following factors were taken into consideration: straight sticks, IV lines, needle gauge, location of blood draw, syringe versus vacuum tube use, and tourniquet time. Hemolysis among the blood samples obtained from straight sticks was significantly less than those obtained by IV lines. The hemolysis rate for straight sticks was 5.4%, or 33 of 615 samples, versus 10.2% from IV lines were hemolyzed, or 4,821 of 47,266, as you can see in Table 2 from the article referenced. The antecubital location had a significantly lower overall hemolysis rate compared with other locations, with the antecubital location being hemolyzed 7.4% of the time, or 2,117 of 28,786, versus 14.6% of the time with other locations, seen in Table 4. Other locations had almost twice as much hemolysation compared to the antecubital location, The large gauge IV blood draws versus smaller gauge IV lines also had a significant difference between hemolysis. The larger gauge IVs had hemolysis 9.3% of the time versus 16.7% of the time with smaller gauge IV lines, seen in Table 7. For IV drawn blood with tourniquet time less than 60 seconds, hemolysis was 10.3% versus 13.9% for more than 60 seconds. It is not pictured by a table, but this is clinically important when talking about factors causing hemolysis. The 1 poke or 2 can intravenous catheters provide an acceptable blood sample article I found was the perfect resource to use when arguing to draw from IV starts. The article analyzed 3 methods to collect and reviewed information pertaining to if IV starts give usable samples in the emergency department. Between May and August 2011, 8,944 blood samples were collected at a 188-bed regional hospital and level 3 trauma center. Blood samples studied were categorized into one of 3 general types based on the patient location and the role of the collectors. The 3 methods by which laboratory blood samples were obtained were 1. By ED staff while starting an IV access, 2. By critical care, medical or surgical nurses drawing from an existing vascular access, and 3. By laboratory technicians or phlebotomists collecting venous samples by venipuncture with a steel needle. The criterion of hemolysis greater than 200 was set for sample rejection in the laboratory. The largest portion of these samples came from IV starts, with 43% of them. Laboratory technicians or phlebotomists using steel venipuncture needles collected a slightly lower proportion of 37%, and the remainder of the samples, 21%, were collected by nurses from an existing vascular access. The table below shows the results of the samples. This investigation provides a record of IV starts in nearly 4,000 emergency department patients in which acceptable blood samples were collected 98.9% of the time. Only 3,000 out of 3,803 patients, only 41 of the samples hemolyzed, or 1.1% of the samples hemolyzed. In fact, all of the following methods included in this study were rejected at rates well below the 2% level that has been cited as a benchmark of best practice for sample collection by the American Society of Clinical Pathology, with blood drawn from an existing vascular access was 0.8% of the time hemolyzed, and steel needle venipuncture hemolyzed only 0.1% of the time. My final source of evidence is my weakest resource, mainly due to the fact of the small census of only 165 samples. This study is still valid due to how it was randomized and is clinically important to this investigation because it includes correlation of hemolysis rates with IV catheter size. In this study, a total of 165 patients participated in it. 87 patients were assigned to the IV group, or Group A, and 78 patients participated in the venipuncture group, or Group B. In Group A, or the IV group, 12 of 87 or 13.7% of the blood samples hemolyzed. Hemolysis occurred in only 3 of 78, or 3.8% of Group B, the venipuncture group. These findings were significantly significant. The study also examined the variable IV catheter diameter and noted a lower incidence of hemolysis with larger IV diameters, with 24 gauge being at 100% hemolyzed, 22 gauges hemolyzed 25% of the time, 20 gauges hemolyzed 15% of the time, 18 gauges 10%, 16 gauges and 14 gauges were 0%. This finding was statistically significant and important when thinking about how to prevent hemolysis. The best way to prevent something from happening is to find the root cause of it. The following are a few causes of hemolysis in blood samples. The following include sampling techniques, sample transport, use of IV catheters, puncture sites, prolonged tourniquet application, underfilling of tubes, excessive shaking of specimens, and pulling back on the syringe too fast. All of these can be prevented not only for IV starts, but for any blood draw. The solution to obtaining the most accurate blood draw is to teach those who do it. Nurses and phlebotomists can be taught these causes and how to avoid them better to prevent hemolysis. As mentioned in the other studies, the gauge of IV catheter and site greatly affected hemolysis. If a nurse were to draw blood, these are to be taken into consideration due to large gauge IVs having statistically less hemolysis. The site also matters, and the anacubical site was significantly less prone to hemolyze compared to the other sites. Even though I had 2 studies showing IV catheters hemolyze more than venipuncture, there is more to take into consideration. The comfort of the patient is a big one. Patients do not want to be poked more than once, and patient care is an important part of nursing, no matter how many policies there are. When nurses draw labs, it also speeds up time of patient care. Henry Dietrich, from my second resource, states, drawing blood during an IV start is a reasonable, caring, and efficient practice that should be provided for patients in the emergency department. If hemolysis of laboratory samples is a concern, effort should be made to work collaboratively with laboratory personnel to objectively collect and review actual data and improve. At this point, I do not believe there is enough evidence to suggest whether drawing from an IV is inaccurate due to the many samples that are sent by nurses and not rejected. My recommendation for this problem is to have more objective studies using standardized spectrophotometric measurements to review hemolysis. The study would also have to be in a controlled setting and randomized with as many samples as possible. My first example had over 50,000 samples, which was its biggest strength, but it lacked the controlled setting. Another consideration is to review the actual cost and delay of treatment in patients compared to an additional puncture. The results I gave from the preceding slides are controversial, but the ways to prevent it are not. I urge education to nurses and any personnel who draw labs so we can obtain more accurate samples and provide the best patient care as possible. The following references are in order of strongest to weakest evidence. Thank you for your time.